Hey everyone, this is Travis Burns. I'm an orthopedic surgeon at San Antonio Military Medical Center, chief of sports medicine, and about to be a member of Ortho San Antonio. And you're listening to Owen's Recovery Science podcast.
Awesome. That was great, Travis. I did the last one, and I kind of spiced it up and said bada bing at the end, but to each his own.
You have more personality than I do.
This is the Owen's Recovery Science podcast, hosted by physical therapist Johnny Owens.
Hello, and welcome back to the Owen's Recovery Science podcast. I'm Johnny Owens, here to host another, hopefully epic podcast. Mostly, again, discussing blood flow restriction, rehabilitation, training, whatever we want to call it. I brought reinforcements today. So we do have Tori Gomez back working the wheels of steel. She just told us that everything we just recorded earlier did not sound great. So we're starting over. Good catch, Tori. We also have Ben Babyface Weatherford back with us.
Hey, what's going on?
All right.
This is I'll redo my joke from earlier of I'm trying to grow some facial hair so I don't have to be babyface anymore.
It wasn't funny earlier, and it wasn't funny this time, but thank you. We also have Kyle Kimbrell calling us in from some random bar at 5:30 in the morning in LA. Kyle, what's up?
What's up? I'm just, sitting here on my custom stool.
Nice. And
with my facial hair that's far superior to Ben or Zach's.
We're not going to get into a beard debate. That's for another podcast. Kyle, I've been trying to figure out the best nickname for you, and we're just going to go with Kyle Bitmoji Kimbrell because you're obsessed with Bitmojis.
I am.
Some of those Bitmojis just crack me up, and some of them get in my head, and I can't get them out of there.
That's the best part.
We have Zach, the Enforcer Dunkel, calling in from the ATL. What's up, Zach?
How's it going? How's it going?
I'll come up with a better nickname for you later. Like I said in the pre-recording that didn't work, it was going to be Zach VEGF Dunkel because you went down that VEGF wormhole for a while, and I wasn't sure if we were going to get you out of it, but it seems like you're coming along. So
it seems to be pretty important.
Yeah. Just okay. So Ben, your quick background. Go, like a minute.
So I am a PT, graduated here from San Antonio from Incarnate Word. I've had the opportunity to work with Johnny since the time I was an intern. And when I was there interning with him, I didn't kill any of his patients, so he decided I was safe enough to bring along. And we've been teaching this for almost 3 years now. Is that how long we've been doing this, Johnny?
Yeah, with you for 3 years, I think.
Yeah.
So, and so you were actually with me pre-intern as an annoying volunteer, pre-PT,
yeah.
I think. It's been annoying me a long time. But
yep, you have not been able to get rid of me yet.
Yeah, I'm working on it. Kyle, your background, less than a minute, go.
Yeah, less than a minute. So originally from the Houston area in Texas, and got transplanted out this way and on the West Coast. So a place called Georgia Herb Physical Therapy. I've been here 15 years in April, just private practice outpatient. And I got interested in BFR like 10 years ago. I read some random article in the Journal of Strength and Conditioning. And then I saw Johnny on Twitter and just Twitter stalked my way into teaching courses for him, essentially, is basically what happened. But we had, what did we do? It was like 3 years ago, we had your very first public course in our clinic out here, right, Johnny?
I think so, yeah.
We had a guy from Switzerland.
Yeah, Audric, and he just chimed in on our inner circle the other day. I still talk to Audric every now and then. Great dude. So basically the same kind of story as Ben. You were stalking me.
Okay.
The
common theme here.
Cool. And Zach, go.
Yeah, so I'd say I took a different approach than the most. Had no desire to go to college when I was in high school. Decided to go in the Marine Corps. served as a reconnaissance Marine in the Marine Corps, had the opportunity to go to Scout Sniper School, deployed to Iraq in 2004. Basically, coming off the end of the tour was, what am I going to do with my life type of moment, and decided I'd always wanted to do PT, and I liked it, just didn't think I was kind of smart enough to do it at the time. And so I had about a year left on my contract coming back from Iraq, and from there, did everything I could to get ready to go to PT school or go to college. And so I went, did undergrad at Penn State, moved down to Atlanta to go to PT school, and did an orthopedic residency with Emory as well, and have since stayed in Atlanta and worked in and around the city.
Nice, man. Yeah, it's cool. So you've got the coolest background than us, you know.
Yeah, for sure. Thanks for showing us all up, Zach.
Yeah.
It's interesting, you know, you're Marine sniper, PT. I just talked to my buddy Dan Roan yesterday. We might see each other up in DC in a few weeks. PT, he was at the Center for Intrepid with me. He was a Marine sniper too. So, man, I don't know what the connection, all that angst or whatever that you have brought into the clinical setting, but it's good. So, yeah, so watch your back if you do something to us. We got Zach Dunkel, if you see that little red light on you. All right. Well, cool. So today's kind of overall theme is a little bit of the where we are at this point after doing this kind of publicly for years now. Just kind of looking at the sheer numbers and the research that's going on in the publications. And a question we get. So we have this private group. It's only for certified providers that have trained with us, and you know, a lot of questions in there are cool clinical questions and other things or case studies, but there's always this one, you know, how do I talk to my surgeons about starting BFR, or, you know, my facility, you know, now we've moved into a lot of healthcare systems, and, you know, what's the kind of best way to get this going? So we're going to kind of touch on that stuff quite a bit as well. But one recurring kind of episode we're going to have here, and I don't know what you call it, but a little part in this podcast is where you at, where you've been, and where you're going for this group of us that are the kind of the core trainers doing it. And so the reason why I got these knuckleheads on with me is because they go out and train healthcare systems, open courses, and a lot of the teams probably more than I do. So it's crazy. Like, my first year of really doing this, I told my wife, you know, you got to be up front. And I told her, I think this is going to be a lot of work and a lot of travel. And I think when I look back at it, I was traveling almost 50 weeks in that first year. It was insane, you know. And like some of it would be like, okay, land, go to Auburn, do Auburn, drive over to Ole Miss, you know, the next day, drive. And so like doing just crazy amounts of courses. And then I was like, man, I can't keep this up. And so Ben came on, and then we just punished Ben the next year. Poor wife didn't see him at all, just traveling nonstop. And now Kyle and Zach are moving into that. Zach, I think you're the freaking road warrior winner nowadays. It's pretty much gone nonstop. Yeah. So anyways, you guys have so much good insight from doing all these teachings. And then what happens is you do a course, you get to know everyone becomes our friend. And then we kind of talk to them all the time, and they give us, you know, I've got this clinical question or this problem or whatever. And so we get a ton of insight from just these thousands of providers that are doing it. That's the one thing we say too, like this is no way like a 1-day course that you're going to learn all this stuff and just understand it, because the amount of questions, the amount of science, the amount of literature that's just coming out makes your head spin. So, you know, once you're kind of in our club, we like to support you, and either through our private group, through sending out emails, or always, you know, pretty much everyone has our cell or our email so we can help answer questions. So that's going to be the goal here. And at the end today, after we do our interview with Dr. Burns, we are going to have question and answers. We got a lot of good questions that came in from our last podcast. And so we got some good questions that I think will also kind of help people. So where are you at? Where you been? Where you going? I'm in San Antonio. I'm back home. I just got back from NorCal, San Francisco. We do an annual course at Kaiser healthcare with my good buddy Eric Robertson and his fellows up there. This is our third year of doing it, and so that's always a blast. I did that over the weekend. I think we had 32 people there. We had Stanford athletic department there. Great to have those guys. They've been they did have a certified provider from the Texans and doing it, but now we're getting more of their department on board. So that's where I just came from. So the first year, guys, when I did San Francisco out there with Eric, I took my family because they hadn't ever been to San Francisco. My daughters, were young daughters. They were like 6 and 8. And so we go out there and we land. We got there kind of early, and they wanted to go like check out downtown San Francisco. And we go down, and it just so happened that day was the start of Pride Weekend in downtown San Francisco. So, man, you want to? I mean,
every weekend in San Francisco.
If you're well, we're not gonna go there. But if you want to really like take your young daughters to Pride Weekend, you might as well do it in San Francisco, I guess, because man, it was a little bit wacky, explaining why that guy's just wearing chaps over there to my youngest daughter. So then we go back to our place, which is near Union City, and I didn't know this either. It was like it's one of the biggest Afghani populations in America. So it was just cool. I was like, well, let's go get some Afghani food. I love this. My daughter's never been that. They sit on the floor, and it was sunset. It was Ramadan, and so everyone was out praying all over the sidewalks. And so my daughters went from first time to seeing Pride in San Francisco to first time seeing Ramadan at sunset out there. And so they thought that place was freaking Bananasville. So anyways, my daughter the other day asked me where I was going. I told her where I was going. She said, oh, that weird place. Anyways, before that, I just got back from Toronto at the NHL Combine, which was awesome. So, or not the NHL Combine, AOSSM NHL, where we met with a bunch of our NHL folks and gave some presentations on where we're going with them. Our buddy Jim McCrossan from Philadelphia was there presenting on performance in BFR. He's got two really cool studies starting up, looking at BFR in the NHL setting. And so that's where I was at. Where am I going? I am going the week after next. I'm at Uniformed Services University up in DC or DC area, doing a big BFR training with clinicians and rehab, as well as a bunch of the docs for the military university up there, which should be pretty cool. So that's my story so far. Kyle, where you at?
Yeah.
Where you been?
Right now I'm in Camarillo, California. Okay. I'm actually not at the bar. I'm inside the clinic, but for humor purposes, I'm usually always in the bar because it's funny. But been here now. Well, let's see. Last course I taught was out in Flagstaff, Arizona, in August. I didn't even know this, but the Indian reservations have like a big hospital system, and so that course was full of PTs that are housed in this Indian type facility. I don't even know how to describe it. It's a whole system. It was really interesting. So I got a little bit of the lay of land when I was there, but there's still a lot I don't really understand about how that works. But it was cool. Those people were awesome. A lot of those guys actually heard you, Johnny, speak at some like resident conference through the military a couple of years ago. It's kind of how that all transpired. And then
it was the Kersey course. That's an annual.
That's what it was.
Yeah, that's a great course. Always we do that every year.
Yeah. And then in a couple of weeks, I'm headed just up the road to Valencia, California, a hospital system called Henry Mayo, to teach their clinicians there. And then later in the month, headed out to Overland Park, Kansas, to do a nice open course out there.
And what were you doing over the weekend?
Oh yeah, that's right. I'm sorry. I totally forgot about it. So over the weekend, I was speaking at a football sports medicine conference that was put on by the orthopedist at USC. It was run by Dr. Tom Vangsness and Dr. Taboni. Dr. Taboni took the course that I taught for USC athletic medicine about a month ago, and then asked me to speak at that. That was an interesting day because it was mostly orthopedic surgeons. We were talking, different surgical procedures and that kind of thing. And they even had a couple people speaking on using wearable technology and force plates and different things like that to try to predict injury, assess movement, that kind of thing, manage load, and then just kind of going through that whole debate that we tend to be hearing with the teams of who owns that information, the players or the teams or the leagues. And I know like the Major League Baseball guys, they can't use the wearable devices now. They were able to for around a year, and then the Players Association kind of jumped in and said, hey, hang on a second, we're not necessarily okay with that, which is an interesting debate. And I tend to kind of be on the side of those guys that they think probably that's really medical information, and the players need to kind of own that, but also understand how to interpret it and implement it into their training regimens, load management, that sort of thing. So that was a fun day. It was a long day, but it was a fun day.
I think that's hot and heavy. Like at the NHL,
it is.
AOSSM conference, that was the first kind of panel was who owns information, who should be in charge really of players' care, because with this unfortunate situation that happened in Maryland, it's
Right.
kind of a lot of this has shifted from the medical side to the S&C side or whoever, and there's a lot of sensitive data, and if you want to talk, the most sensitive data is the TBI data, baseline and then post baseline changes, and there was a collaboration with the NFL and the DoD, and that's the DoD is prepared to kind of measure baseline TBI data, and it changes in it, and then you get paid a disability. But ooh, boy, that's a hot topic with these type of.
Yeah, and it seems like they don't necessarily know how to interpret all the data either. It's like, all right, we have all this data, but what does it mean?
That's that we could do a whole podcast on that. I mean,
yeah,
we go to these teams, and it's like they measure everything. I mean, shoot, over in Europe, the amount of data collected is crazy. And then it's like, okay, do you even know what that data means? But then, okay, once you get it, can you change that data? Is it meaningful, even if you understand what it means? So yeah, we're in data overload, and so we're gonna use that out. Was that a Curlin Job conference, or was that a USC conference?
No, it was USC. They do it. It's a yearly thing. And then interestingly enough, one of the ladies that was speaking on all the wearable technology and all that, they actually have a body computing conference at the end of September out here at USC as well, which sounds really, really fascinating. So
you have to check that out. Dr. Taboni, man, it's cool he's such a cool dude. Yeah. So I got to hang out. I spoke at the Pac-12 conference in Vegas a few months ago, and first time I really hung out with him. He's cool. But we'll say if you text anything to someone or to him and you write Taboni, it will autocorrect as Dr. T-Bone, which I think is kind of cooler. But
it's awesome.
Yeah, I'm sure he's heard that before.
When you type my name, it just defaults to a Bitmoji of me. So
mine defaults to a dork. All right, Zach, where have you been?
Yep.
And where are you going?
So I'm currently down in Atlanta. A couple weeks ago, I was up in Jersey, did a private course up there at Ivy Rehab. And then just last Wednesday, I was up in Fayetteville at Fort Pope, worked with different JSOC guys and guys in the Air Force, working with CCT guys. So pretty good course up there. It was unique to kind of get that perspective of that, having been on the other side of it. So it was really cool to see basically how the Army, the Special Forces groups have integrated their Thor program into the treatment of soldiers, and then kind of how they go about the transition out of rehab into strength and conditioning, and then just kind of monitor them from there on out. And then headed to Indianapolis in a couple weeks, about 2 weeks, to an ATI up there.
Cool. Yeah. So we got this ATI enterprise-wide doing all these trainings all over the country. Yeah. So Zach, were you actually at Pope or Bragg? Where did they end up doing the course?
So it was at Pope.
Okay.
And then where we were at was in kind of like a treatment room, and then like right down the hallway was their gym facility, which was pretty sweet.
Yeah.
You know, I mean, you know, think of it as like, I mean, it was like a collegiate strength and conditioning room. I mean, they had squat racks lined up along the walls, various bikes, treadmills. I mean, it was a pretty a climbing rope was hanging from the ceiling. I mean,
It's still
you know,
that
they had AstroTurf.
still that outside
What's that?
It's that little outside bubble type warehouse, right? That they have the strength.
It is. Yeah. So yeah, it's like in a metal tin building, and then within that, and then they have an actual outside area where with AstroTurf where they can, you know, push sleds, do whatever. So
yeah. You have to use porta potties too.
I didn't go to the bathroom. I conditioned myself
The whole day you didn't go. That's crazy. Yeah. Well, I did.
yeah.
I only did number one though because
I
I
don't-
was porta potties.
I don't have those prostate issues yet. So
yeah. Well, I do. So yeah, and those guys, I mean, they've already been doing BFR, especially over their Pope. So we're getting some cool things from them because the one thing too is a lot of the combat casualties are still the special forces. I mean, we don't have forces, you know, really big force over there anymore, but the SOCOM are the ones where we're seeing a lot of the injuries we saw during the war. So those guys are really giving us some good information still of what to do with it. Did you get to meet Ania? Did you all hang out?
No, she actually had to an appointment with one of the operators there. So she sent Cal, which was a gentleman that she works with. So I met him, pretty cool guy. And it was really cool. Like I was texting you about how they basically are using the data from the one study where we talked about Losartan and PRP.
Yeah.
They've implemented that with some of their folks. So it's pretty cool to look at that and, you know, kind of translate that, move that out of the rodent model into the human, and see basically if we see a similar carryover with that reduction in fibrosis and maybe even regeneration of the muscle. So.
Yeah, that's what's really, and that's what was great during my times, you know, especially during the war, is how quickly we can kind of move into the clinical practice with a lot of this stuff. I mean, I think that's what really catapulted BFR, obviously, into the clinical setting was just the massive amount of it that we were able to do in the DoD during the wars. So I was at the Special Forces Conference presenting several months ago, and Dr. Lynch up there, we met afterwards and started talking about just some of these early preliminary studies that we have, and it sounds like he's already applying it. I mean, even with orthobiologics, right?
Yeah.
Yeah. We'll get deeper into that. All right, Ben.
All right. Well, as Johnny said, I'm right down the hall and here in San Antonio. I just got back yesterday from Boston and did a course with the Bruins up there. And 2 days before that, on Saturday, I was over at MedStar just outside of Baltimore. And this is it's apparently the NHL time, I guess, because they're about to start camp up pretty soon. A few weeks before that, I was over in Nashville with Vanderbilt and the Predators.
Yeah.
So we've had a lot of NHL movement here recently.
Well, NHL was our most lagging professional teams as far as who we've worked with of all the leagues. So it's good, man. They're stepping up.
Yeah.
And
so
the Bruins had to be like the coolest facility. I wish I could go out there and see that.
That place is awesome. I mean, it's a pretty new facility. They're actually right next door to the brand new facility for the Celtics. Apparently, New Balance built everything up over there, so everything's brand new. It's a couple years old, but it's really cool. They've got, I guess, the second most championships, or tied for the second most championships in the NFL or NHL. So they've got all the trophies in there and all the history on the wall. One of the original 6 teams in the NHL, so definitely a lot of history there. Very cool to see, and they've got some very, very cool equipment.
Yeah, imagine. And where are you going?
So I am headed to scenic El Paso, Texas next. So after I piggyback on that San Antonio course with you here on the 15th, I'll be headed to El Paso, and then over to Orlando, Florida at the end of the month to speak at the Florida PT Association conference.
Nice. I love El Paso, man.
Yeah,
I always like going out there. Cool.
I've never
Are
been,
you
so
training
it'll be
Louis?
interesting.
Is
What's
that
that?
Louis Zuniga's place? Is that
No.
Louis'
No,
place? Ben?
it's another group over there. So
Oh, okay. Very cool.
Yeah.
private course though.
Yeah, we do a lot out there with Fort Bliss, and so the patients that are seen there that go out on the economy outside the base, since a lot of the docs there we know, and they're looking for BFR. They're trying to find places out there that are certified and doing it. So cool, good stuff, guys. Well, so I guess this is just kind of open discussion here. You know, we don't have a full this is our theme. Some of the other podcasts, you know, it's going to be like, yeah, okay, let's get into deeper what VEGF is or what we think's happening with fibrosis or whatever. But this is an overall kind of where we are. So at this point, I had Tori pull the database earlier. We have 3,399 certified providers from this last 3 years that we've been doing this, which is that's pretty amazing, man. That it's taken off to this point. And so I was talking with someone and they said, you know, one thing that's almost better than the clinical trials that we're looking at is just getting this kind of longitudinal perspective kind of data and even retrospective, like looking at how many BFR sessions have been done. Were there adverse events? If they are, what were there? You know, what are key changes that you're seeing to help kind of, you know, that's almost more powerful than a study of 100 people. So I broke this down. There's 261 calendar days in a year on average. Out of those 3,400 certified providers, you know, not all of them have a unit that they're working with. A lot of them are certified, but they go like ATI, you know, they're going back, you certify a group and then they go back and there's a few units there. But I did look at, you know, the number of units, you know, and so we're, you know, around 2,500 or so. If only two of those, or if only for each of those units, if there were only 2 BFR sessions a day, which we know there's way more per unit per session per day. Because like Kyle, how many BFR treatments you do with one unit at your clinic on a daily basis?
4 or 5 typically.
Okay, so I'm just lowballing it here. Just at 2, that's 5,000 BFR treatments a day that we have people doing, which that's pretty badass. And
yeah, because Johnny,
go ahead, Zach.
I was going to say the other thing to think about with that is, like in our clinic, we have other people that use BFR that aren't certified providers.
Right.
So that's a low ball figure for sure.
Low ball, yeah. And so I just wanted to kind of, even at a low ball, if you do that 5,000 per day for 261 working days, that means we have 1,300,000 BFR sessions a year going on. At a low ball, it's probably triple that, you know. So potentially 3 million BFR sessions in a clinical setting a year, from everything from geriatrics with total joints to, you know, your just typical orthopedic injury to some neurologic conditions, down to peds. And so I think, so one thing when you're talking to your surgeon or trying to discuss this with, you know, your clinic director or whoever, that's kind of an interesting number to already know. Like, well, there's over 1 million, there's probably over 3 million sessions of this going on in the United States right now. And this is also, because we have so many teams, this is also high value targets that are going through these sessions, you know, multi-million-dollar arms and legs that are getting these treatments. You know, the Delphi unit that we use, it's on workers' comp in all the professional leagues. I see these comp claims, and these are, you know, pretty much anyone that gets injured, especially now in football season. If it's an orthopedic injury, they're getting some form of BFR, and so I think that's just kind of the first thing. People just aren't used to it, especially if it's new to them. Of like, well, I'm not sure, you know, are people really doing this? Yeah, they're doing it a ton, and that doesn't even count now, you know, our European folks that are doing it and things like that. You guys have any thoughts on that or things to add on total number?
Yeah, I mean, like I said, I know that number is extremely low, and it's like Kyle said. I mean, you're just factoring in basically 2 patients a day, and if you take in even a normal outpatient clinic, and you just say an 8-hour day, if you're treating probably at least 12 people,
Right.
So it's going to be significantly higher. And then you factor in the people that are in the clinic that haven't been to the course, that are going to use BFR because they were taught by the provider that went to the course. So
Right.
yeah, it's going to be a lot more than that.
And so I think also then it's what are the reported adverse events of that? Because people look at the literature and say, okay, is there a reported adverse event? What you really want to know is, how about in these clinical treatments? Are there reported events? Because the literature, you're talking maybe thousands in the clinical setting now. We're talking millions of treatment sessions. And so what are the reported adverse events? And one thing, we have a pretty controlled group because we know that our people are trained and for the most part do it the way we teach it. And also we're standardizing our approach. So we're using a system that, FDA device, it's got a microprocessor, it's regulated. So we know the pressures are at this level. We're using the Doppler within the system to know LLP. So it's a pretty standardized approach. Really, adverse event wise, pretty much nothing. There are a few things. And so there's a recent paper that just came out on a military service member who did BFR and developed rhabdo. And that's probably, if you Google like BFR bad, other than maybe seeing my stupid face on that picture, it might, what you probably see first is, rhabdomyolysis, because that's what's been reported in the literature. So now we're at 4 cases, right? Total reported in the literature.
Yep.
Is that right?
I think so. Yeah.
Yeah. So if you just do that number though, and that's over years. I think the first reported case was 6 years ago now. But if we said if there was 4 reported cases in 1 year, and we just look at that divided by those million case sessions, that is a 0.0004% incidence rate, which is, that's lower than just rhabdo in the general population by far. So if people throw that out too, like, well, yeah, but I've seen there's rhabdo. It's like, well, and Jamie Burr up at University of Guelph, I never know if I say that name right, in Canada, he wrote a nice editorial response along with some of his colleagues up there of like, let's not freak out about this rhabdo thing. When you look at the denominator, it's huge compared to this low numerator up there. And mechanistically, it just doesn't make sense to get rhabdo after BFR. Do you guys agree with that?
Yeah.
Yeah, absolutely.
So rhabdo is, and if anyone's listening, don't know what that is. Rhabdo is basically severe muscle damage. It breaks down. You get a lot of fluid leakage, swelling, a lot of pain. You start to piss brown. If you're a clinician and someone ever walks in with any of those signs, you send them straight to the ER. They will take a blood draw and measure for creatine kinase. If CK levels are elevated to the certain threshold, then you admit them to the hospital. It can be life-threatening. Usually it's admit, get them on fluids, monitor, and then discharge. But from what we pretty much understand with the BFR mechanism side is there's not muscle damage. And if there is, it's very, very mild because BFR is a low load. And typically rhabdo is intensity based or it's load based, long times under tension, et cetera, et cetera. So we don't think mechanistically there's a real play with rhabdo. That military case that came out, it looked like they just had a volume issue. The guy did 1 session of BFR calf raises. He did another session of BFR seated calf raises. He did another session of BFR for ankle exercises. I forgot what it was. I think it was eversion and plantar flexion, something like that. Each one of those sessions is 75 reps. So the dude did like 300 BFR reps. 300 reps of anything is a potential issue. So we think that one was a volume issue. The first reported case was a hockey player over in Europe. And if you read closely, the player was doing some BFR post-op. He developed rhabdo, but then in the conclusion, they said once the player got out of the hospital, they restarted his BFR sessions. So I don't think the authors were even concerned that BFR was the causality of that. And the other ones, there were things that you can look at for potential rhabdo producers. One was sick and on some medications. And so those are the things I think that we just want to say, well, let's at least look at this with a grain of salt. You guys agree with that?
Yeah, I mean, I think like you said, it looks like as long as you're dosing it appropriately, the risk is very, very, very minimal.
Yeah, I mean, direct markers, we've seen those. Blood draws, CK levels don't seem to be elevated. Myoglobin leakage, which is even a more sensitive marker, we don't see that happens after BFR. Jacob Nielsen's group and Per Argaard over there in Denmark, they did show that your body kind of responds almost like there was a muscle damage effect. So heat shock proteins were released. There were some inflammatory markers, which are things you want to happen from resistance exercise. But the actual signs of muscle damage weren't there. And they did measure for, changes in myoglobin leakage, which is a pretty sensitive test, and they didn't show that. So if anyone throws rhabdo at you, I think we can definitely talk through that and say, look, I don't think we should be concerned with this. If you are concerned, and if someone's had rhabdo or there's a potential that they could, then you should probably screen for that. And maybe athlete, these teams that works with athletes who are doing a lot of intensive exercise outside of BFR, TT screen, TIE, TZE, I think. That one is just a real basic one. It's a check off. If you've had any of these things, then we might need to monitor you a little bit closer. So that's the main thing that we've seen out of these millions of clinical cases is a few reports of rhabdo. We've had a couple of syncope episodes, 2 total that I know of that have been reported. And so both females, both after we were able to get a little bit deeper into maybe potential outside factors, both looked like they were dehydrated from different things. Well, both of them dehydrated probably from being kind of sick prior to doing that BFR session. So that might be a hydration status. Not sure, if there is a female thing, probably not. Or even Dr. Cahalan, who's on our science advisory board, he's our kind of go-to cardiac rehab guy. He said there is a vasovagal response in athletes. A lot of them are just known to pass out when they see a needle. And so maybe that's correlation with those. We're not sure. Other than that, I don't think we've had any reports of any other events that have happened. You guys have anything that y'all can think of?
Nothing that I'm aware of. The only thing I've maybe heard is, a little bit of, joint swelling acutely after, applying it early post-operative, but that seems to be pretty transient and go away quickly. And after a couple sessions, doesn't really seem to be there.
Kyle, Zach, anything you've been reported from all your folks you work with?
Nothing on my end. When we were testing the new device and the engineer was here, we had a couple people not be a fan of the pressure, but
yeah.
It was more entertaining than it was a problem.
Well, yeah, and that's obviously not an adverse event, but it is. I mean, it is kind of rough, and so
it is. Use this story. You have to factor in.
Yeah, I mean, we had a female service member one time who said, I can't even stand when they do the blood pressure cuff on my arm. And we're like, oh boy, you're going to hate this today. So, and that's right. And you don't have to use the pressures that we recommend in those cases. I mean, you can take the pressure down prior to application, maybe use a lower limb occlusion pressure or personalized tourniquet pressure. And if they tell you already I'm a little squeamish, I would definitely start with a lower pressure and then ease them into it. What about you, Zach? Anything?
Yeah, kind of similar to what Kyle said. I've had, I think, like 1 or 2 people complain of like claustrophobia. So they said like basically with a cuff on, they just started getting claustrophobic. But it's only been, just a few people. But I was pretty surprised because I had never even consider that being an issue until it was a military guy told me that, and then probably 2 weeks later, I had another lady tell me that she was getting claustrophobic as well. So that was it.
Yeah, and they might be just getting a little bit anxious too. I would think.
Yeah, it could be that from the pressure, just like like Kyle was saying. Sometimes, because it's like you said with the lady in the military. I mean, that pressure gets a little tight. So
yeah. Well, and so I guess back to our roundabout point then. What you're going to see reported in the literature primarily is those rhabdo cases. Beyond that, we really don't have any other adverse events that we can say that we're worried about. And now we're at millions of clinical BFR sessions a year over several years now. So that looks positive, because when you take our course, we definitely go deep into the safety of BFR. We were lucky here in San Antonio when we were starting at the base that we had tourniquet experts, we had physiologists, we had our orthopedic department, our rehab folks, all kind of vetting the safety first before we moved forward with doing it on warriors. And we got really we had to understand exactly the best and safest way to apply it, which is what we do. But really, after we looked at it, it's like, man, this looks really fairly safe. So again, if that's thrown at you from a surgeon, a doc, your clinic director, your own fears, I think that's something that we can put aside. Okay. So then what do you guys do to, like, I'm talking more to you, Zach and Kyle, who are doing it more in the clinical setting every day now. What do you guys do if you got a new patient from a doc you haven't really worked with, to say, hey, I want to try BFR on this post-op ACL?
Well, I talk to the patient first. Because they're right there in front of me. And nowadays, a lot of the docs out here are at least somewhat familiar. We did have one this week who was not, and so my boss just called up his office, and we're gonna go down there and chat with him at some point and kind of explain some things. We just sent him those 2 Journal of Arthroscopy articles that just came out, and those techniques and orthopedics papers that came out, and then I'm probably going to shoot him over that pre-op total knee one and a couple of those ACL ones too. So we shared some articles with him, but I think mostly you need to be able to have a conversation with the surgeon, because those guys don't want to sit and read, paper after paper after paper. They want to see that there's literature out there, but they don't have time.
Yeah. What about you?
Conversation and understand it all.
What about you, Zach?
Yeah, I tend to agree with Kyle. So a lot of times what they'll say is like, well, send me some level 1 evidence. And so you send them that, but then if you can have a conversation and realize that the surgeon the orthopedic surgeons are pretty busy. And so if you can just get a 5 minutes, 10 minutes with them and say, like, look, what are some of the problems that you see with your ACLs? Because we know the issues on the rehab side. We have prolonged atrophy and a lack of quad strength, and the data is there to support that. Mm-hmm. And so we know that it's an issue, and we know that we have surgical limitations in the early phases of rehab. And then we have data that says, within a week to 2 weeks, it takes 12 weeks of high intensity strength training to get that back. All that stuff is great, but they know that we have these issues and say, like, look, we can abide by the surgical limitations or that have been placed on us, and we can minimize this atrophy, help them and expedite the rehab and get them back to where they need to be at a faster time point. And we have some ACL studies out there that actually show this. So that's what I'll do. And I will say, I think that one of the biggest things that I hear from surgeons is like, no, I don't want to do BFR. I don't want to restrict blood flow. My surgery or my repair needs all the blood flow it can get. Yeah. And so when that question or when that comment comes up, you need to be able to basically say, well, look, it's a transient reduction of blood flow. What we actually see is once we deflate the cuff, we have a surge in post-occlusion blood flow, And then, when we do this chronically, we have about a 14 to 15% increase in capillary density distal to the cuff. So we're actually stimulating blood, capillary growth and an increase in long-term blood flow. So this could be a very good positive effect for us.
Yeah, I think that's, that whole, well, I don't want blood flow stopped because my repair needs blood flow.
Yeah.
That's one of those like, oh, okay, here we go. But yeah, I think if we can explain a little bit of like, brief bouts of oxygen deprivation or hypoxia in a limb, it seems to be a very positive effect for a lot of things beyond just the muscle. But once the bone gets into a low oxygen state, you get this HIF1A expression, and then vascular endothelial growth factor comes out and creates angiogenesis, which is, if we can see that change intra-articularly, man, then we're looking at stuff with our ACL repairs. So yeah, that's good. That's good stuff. And we're going to talk about these kind of like what are some go-to papers maybe to send out. You guys don't use a consent form for the patient, right?
No.
I think, okay. Zach?
No.
Yeah, correct, Johnny. We don't. And then really the only time we go to a surgeon or a physician is following a surgery. If someone comes in, is referred for conservative treatment, or they come in direct access, we just go ahead and, if we think BFR is needed, we'll just go ahead and do BFR.
Yeah, and that varies state by state, obviously. So, and we ran that question through our inner circle. How many people use patient consent forms? And by far, the majority of the group doesn't. And so I ran that question by my buddy Justin Moore, who's the CEO of APTA, of what from an APTA standpoint, what do they think? And basically agreed with what our current practice is, that if something's a higher than normal risk, like you're going in for surgery, you have to sign a consent form because that's a higher than normal risk for something that you're doing. As BFR, basically looking at our overall safety profile, it doesn't seem to be a higher than normal risk type of thing. So there's no individual consent that's needed. Now, it sounds like Justin, those guys are going to look at it a little bit deeper to get, maybe rubber stamp that. But that's a question we get quite a bit. And I guess we can fall back, we have all these clinical trials going on all over the place, 20 something just of our own. For the IRBs, we've never had to go into an IDE, like an investigational device exemption, because this study was deemed higher than normal risk. So even in the studies too, we don't have to deal with it being a little bit more higher risk than normal. So papers then, Kyle, you said you send out the 2 J arthroscopy papers that came out a couple weeks ago. Let's kind of talk about those, because I think those are awesome because they're level 5. So, we'll say that. But lots of times, like you said, if you send the doc, well, hey, here's a level 1 JFIS paper that, that talks about all these kind of factors and positive adaptations that happen at BFR, their eyes are probably going to roll in their head whenever you hand it to them. But for people that don't know, Journal of Arthroscopy is a pretty big dog orthopedic journal. So I looked it up. Its 5-year impact factor is 4.6. They are the official journal of the Arthroscopy Association of North America, ANA, and so they typically are not putting rehab papers in their journal. So let me see. I pulled up the other day. Let's see what a typical journal looks like. So here's the current issue. Anterolateral ligament. Let's stick to the facts. Arthroscopic subacromial spacer implantation in patients with massive rotator cuffs. Arthroscopic partial repair, repair rotator cuff. So it's all surgical. And most of your sports med docs or just general orthopedic surgeons get J arthroscopy, and that's kind of one of their go-to journals. And so in this most recent article, they put out 2 rehab level 5 evidence papers specifically on blood flow restriction, which that's pretty cool. It's crazy. And so,
Very cool.
yeah, the first one was from Dr. Brian Day, who is a very well-respected orthopedic surgeon out of Canada. And so Dr. Day was the past president of the Arthroscopy Association of North America. So pretty much all the arthroscopy docs know of Dr. Day. And he basically laid out like, look, this BFR stuff, it looks positive, and I think we should be looking at doing BFR. I mean, he even broke it down to like, I want certified providers doing it who understand the use of a tourniquet and understand how to do it. He even put in there, I also want the Delphi system used because we can standardize that. It's the safest approach and all of that, which was all pretty like, wow, that's cool, Dr. Day. So I think that one was huge and impactful. And then the second paper in that same journal was from the folks over at Stedman Philippon, and an author from Howard Head. And so if you guys don't know, Stedman Philippon, it's out in Bell. It's one of the top orthopedic groups in the country. It was Stedman Hawkins, and now Dr. Philippon's name is on there. But it was from Dr. Laprade, was the corresponding author on it, who is the medical director for Stedman Philippon. And basically, he's the multi-ligament knee doc guru out there. So, pretty much all the Olympic knee injuries go see Dr. Laprade. And basically, he put out a paper saying this is what we think should be done post knee surgery with BFR, and basically also rubber stamp that we think BFR should be done after these knee surgeries. So I agree with you, Kyle, sending those over to the docs. Those are good ones because they kind of sum up the evidence, and then they say, look, I do this, and this is how I like to do it.
Right.
So do you think your docs now, when you send that over, have they said anything to you since using those, Kyle, or are you just it's kind of your packet?
Yeah, kind of my packet. I haven't really had any feedback on that yet. We've got people that we kind of talk to routinely, and so a lot of times when I get something, I'll just shoot it over so that they have it, and then you can kind of refer back to it later when you're chatting with them.
Cool. I think they're great to have in your kind of arsenal. Then the other one you mentioned, Kyle, I think is good. I was guest editor on Techniques in Orthopedics, which is another orthopedic journal, and we basically were able to do a whole journal just on BFR. So we had I think 5 papers from a bunch of my buddies around the world here. So that one is everything from Jeremy and his group down at Ole Miss wrote the mechanisms of BFR. Myself and Dr. Cahalan and the folks down at Miami wrote safety with more of the higher risk patients like the hypertensives. What we know so far, we did a meta-analysis systematic review. Bradley Lambert, who's a really smart muscle phys guy down in Houston, and his group wrote on the anabolic effects that we see and how we can apply that clinically to maximize protein synthesis. Kyle Hackney, who was at NASA, now he's at North Dakota State, super smart guy, along with some of our military docs, wrote how we can use this for the sarcopenic, the elderly patient. Luke Hughes and Stephen over in England wrote on BFR and its application post-surgically, especially with ACL. And then Dr. Bradner and Stuart Warmington, they're in Australia, and Cutter out of Aspire wrote the side effects of what BFR is and the things that we might want to be aware of. If you're like, what's like one go-to source where I can get all the information? I mean, I think that's like perfect for the clinical setting. Don't you guys agree?
Yeah, that's probably the most comprehensive thing out there we can pass along. That's probably speaking their language because it's in one of their one of the docs journals.
I would buy that journal. I don't get any kickbacks from that, but I would buy that journal and hey, here, if you're concerned, why don't you read this one? This is in one of y'all's orthopedic journals. It's got all these papers basically explaining this and how and why we should be doing it. And then I think some of the other papers, Kyle, you mentioned the prehab one from the guys over in Dusseldorf in Germany.
Yeah.
That one's awesome. Dr. Franz and Dr. Zilkins. Dr. Zilkins, he's the chief medical officer over this humongous healthcare system or hospital system. He's the head of endoprosthetics care. And they basically, so we have a study going with them in total hips, but they wrote a great hypothesis paper of like, this is what we think BFR can do from a prehab setting prior to surgery. Because I think that's an easy like way to get in to the docs too, is like, okay, if you're nervous about it surgically, how about we do it pre-surgery? All right. Or how about we do it when you think you're far enough outside of surgery, but this patient isn't doing well. That was kind of the way we started was, okay, it's 12 weeks out. This patient's struggling. We feel pretty comfortable that there's no surgical issues anymore. Let's go ahead and try it on this patient and just see what the effects are. So I think that's a pretty good approach.
I can tell you, Johnny, my uncle actually had a total knee. It's been about a year ago now, and he needed a total knee for probably about 10 or 15 years. And so I have the images of his knee intraoperatively, and it is scary. It's amazing he was still walking on that thing. But I got him in with a buddy of mine to do BFR preoperatively. And he was really just amazed first that he was able to feel his quad, and he got some muscle back. And then post-operatively, the doctor was like, I just don't want you doing that BFR thing. But his recovery was fantastic. I mean, I think he was discharged from PT in about 6 to 8 weeks and feeling better than he had in, 10, 15 years for sure. He was going up and down ladders. He's a blind guy, so does window coverings and that sort of thing. And so he's got to be up and down ladders for his job. And he bounced back remarkably well. And he really kind of gives, I mean, it's just an N of one, but he personally gives all the credit to doing all that BFR work preoperatively.
So I thought cool. I thought you meant he is blind, like he can't see.
I know. The best part is that the name of his company is The Blind Man, and so he has on the side of his truck driving around town The Blind Man.
Well, and so like it's been great that we've helped and worked so much with these pro athletes and these soldiers. But man, this guys like him, this sarcopenic geriatric population. I've always said this, and I think you guys all agree, that is the group that can probably benefit the most from this. And so I mean, I think that's the perfect approach, because a lot of these total joint docs are really anxious, especially with their incisions, et cetera. But most patients have to go through therapy and kind of fail therapy before they get approved to get a joint replacement. So, I mean, that's like the perfect time, I think, because you might not make them avoid joint replacements. We actually did see that with a few that we saw at Center for the Intrepid. They just got better. I had one guy, he's like, I just need to get up my stairs to go to my second floor. And he got to where he could do that. He canceled his total joint surgery. But at least you're sending them in with a pretty good muscle, because that just kind of gets ignored lots of times. So, yeah, man, that's the perfect target. And then lastly, and Tori's going to put links to all these papers if people want to go after them. We have a bunch of DOD papers that we can put on there too. And every one of these DOD papers, there's an orthopedic surgeon that's involved in that study. So Dr. Burns, who is a good buddy of mine, who was with me starting this from the get-go, he runs our sports medicine program here. So he's on them, and as well as like AJ Johnson, who is the chair of all orthopedics. So those I think this is just kind of a good start to get in people's minds. Kyle, you're going to have to get going and do patient care, right?
Yeah, here shortly. I got about 7 minutes.
Okay. Well, unless you guys have anything to add to that, just kind of general, these are some of the go-to papers that aren't the deep science papers that we'll get into. Adverse events, how many sessions we do. Anything y'all want to add before we move into our interview with Travis?
No.
I think that just about has it.
I was that badass, or I just talked that damn much. All right. Well, we're going to cut to an interview here with a guy who was with me from the very start of this. He's a co-author on our very first BFR retrospective paper in the Journal of Special Forces, Dr. Travis Burns, to kind of talk about his thoughts when we first came to him with this crazy idea and moving forward with it, where he thinks it's going, and then also just kind of some general orthopedic questions, which I don't think a lot of the therapists get to hear enough of his concerns with his surgeries and what he hates about rehab and loves about rehab, and et cetera, et cetera. So, all right, guys, I'm going to cut out and do my talk with Travis, and then we'll be back to take some of the questions that came in from our last podcast. All right, so now we're moving into our interview portion of the Owens Recovery Science podcast, and so I really wanted to take a step back. We've been talking about discussing this with your referring orthopedic surgeon or referring doctor, and how you would get this ball going. And so this is one of the OG episodes, which I've got Dr. Travis Burns on here. He's not super hip, so Travis, OG is hip language for old guy. And so,
I appreciate that.
Yeah, this is the old guy episode. But actually, Travis was in the early days starting blood flow restriction at the Center for the Intrepid and our base, San Antonio Military Medical Center, and really kind of helped us to bring it forward, especially in the post-operative patient. And so just want to give Travis's bio here. So he did a sports medicine fellowship at West Point. He's the chief of sports medicine at our base, San Antonio Military Medical Center, for the past 7 years. He's making the big leap, man. How much time do you have left until you're completely out of the military?
I'm actually starting clinics next week, so
nice,
it's happening quickly.
Nice. Well, congratulations. That's a big change. So he will be moving out of the military setting. How many total years in the military?
I'll be at 15 years when I get out.
15. Okay. So 15 years in the military. He's a West Point trained sports med fellow. He did sports team coverage out at West Point, covers a bunch of the high schools, works with the U.S. Olympic team. Very published. A lot of us in our group, especially during the war, were really able to get a lot of good publications out, and so he's just a great person for us to have on board for this first one. So, Travis, I guess let's go in the Wayback Machine here. So we kind of talk about when we give lectures on this or teach it that we had kind of three target populations that we were having problems with at our base. The first one was our limb salvage group. We developed this exoskeleton that was trying to help them avoid delayed amputation, but if they weren't really strong in their thigh, we found out that thing just didn't work. And then most of these people who had really bad trauma couldn't tolerate loads at all, so we had to find a low load alternative. And so that was one target group. Second group was these volumetric muscle losses. So we found that people who'd lost chunks of muscle, we really didn't get any regenerative response. And they would just kind of stall out on strength. So working with the Institute of Surgical Research, we were looking at minced grafts and ways to regrow muscle tissue. And we found that if you did apply this regenerative type of approach, that you had to get some sort of big anabolic stimulus to make the muscle respond and hopefully reduce fibrosis. So that was a second population. And everyone thinks during war that, we're primarily seeing amputees and limb salvage and blast trauma. But, Brett Owens and those guys put a paper out that 10 years of war, they looked at the ACL rate, and we had 50,000 ACLs during that period as well. So the biggest population really is the folks that you were seeing, and that's the typical orthopedic sports medicine population, the ACLs and other types of injuries like that. So I guess I don't think we can remember like when we got together, kind of discussing BFR. Our first three papers that come out of the DoD, you're on all three of them. So I don't know if you know this, but I think you're the most published BFR orthopedic surgeon in the country now. You're the expert.
There you go.
But I mean, what were your first thoughts when we started to say, hey man, we're going to put tourniquets on people, knock their blood out, and do these exercises with a tourniquet on after your surgeries?
Yeah, I don't remember the exact date either that we had those conversations, but I very clearly remember you calling or us get together and talking about it, and you say, hey, I've got this idea to use tourniquets to increase strength recovery for quadriceps muscle weakness, post-op recovery. And certainly at the time, as a surgeon, you start immediately going to what complications can come from this, and you certainly want to think about things that can cause a problem. and think about it to make sure that you're not going to make something worse before you make something better. So, from that perspective, the first thing you start thinking is, are you going to have wound complications from this? Are you going to, induce some type of DVTs that could lead to PEs? Or is there, some other secondary gain or secondary injury that could come from applying something after surgery? So those were all the thoughts that I immediately had. But when you started showing me some of the literature, certainly the strength training that was done initially on it, not in operative patients, the literature and the information was compelling. Something like, this is something that's really interesting. And I think after those initial conversations, with my background of sports medicine and also trying to delay the old guy phenomenon, try to get to the gym and work out in the morning. Joe Alderetti and I would take tourniquets and started doing squats with tourniquets on our legs initially, just to see what it felt like and see what kind of problems we were going to cause to ourselves before we looked any further. And just using them ourselves, you could tell that something physiologically was different whenever you were exercising with some amount of occlusion in your muscles. And so that was really interesting, just trying it ourselves and then kind of putting our heads together and start trying to think of ways, how can we go about this in a scientific way to make sure that it's safe, and how early we can use it in the postoperative period and still allow it to be safe. And so, and obviously in the evolution of how this has grown, it's really taken off. I think that speaks to how effective it is. I think, it seems like every day there's a new technology or a new injection or, new stem cell that comes out that people want to try as the latest and greatest. And those things have either pretty quickly faded or
a lot of questions around it.
Yeah, that's right. And so, I think in all the data that's come out about this, and as that body of literature is growing, has certainly shown how effective tourniquets can be and how safe they are.
Yeah, it's interesting because from the orthopedic surgeon's perspective, you guys deal with tourniquets all the time, so you're used to it. But they're kind of a means to an end. It's I guess it's almost like a love-hate relationship because there's we know in the joint population, put a tourniquet on, the longer you have it on, there might be more postoperative pain. There might be more issue getting the quad going. And so I know when I talked with Walt Lowe initially down in Houston, that was this thing like, hey, I get tourniquets 100%, but there's things that happen with tourniquets, but I think y'all's just comfort level with it made the ortho side buy in much quicker than say like some of the primary care docs that that we hear these clinicians talk to, or non-surgical kind of MDs that are like, yeah, all we know is that tourniquets are bad. So I think getting you guys early on has helped this a ton. So who handled those workouts better, man, you or Joe Alderetti?
Joe's a lot tougher than I am, so he did more. But I would tell you that one thing I would throw out there to anybody who has any concern about use of tourniquets and are we causing damage, is the tourniquet pressure in your BFR use is much lower than the tourniquet pressures that we use in surgery, and it's much lower than the old tourniquet literature where they were showing complications. So historically people talk about inflating tourniquets to 350 or 400 millimeters of mercury historically, and would talk about complications related to that. And in surgery now, people use tourniquets at 250 millimeters of mercury to 300 millimeters of mercury, and can use it up to 2 hours continuously. And that's a lot different than the tourniquet pressure and the time use when you do it for BFR. I mean, for BFR, it's up somewhere around 100, 150 millimeters of mercury, and you're only doing it for 8 minutes at a time. And so I think for people who have concerns about tourniquet use and their safety, and they're looking at old surgical literature, they have to make sure that they recognize that it's a significantly different pressure and a length of time that it's being used.
Yeah, for sure. And so let's kind of, what diagnoses are you primarily using it with now? So let's just start kind of low level, like routine scopes, BFR. Yes or no? Yeah.
I would, yeah. Honestly, I'd love to use it for everybody. Our biggest limitation is in having availability to get to the therapist that can do it. I would use it for 100% of my knee surgeries if we had the capability to do that. Unfortunately, we're a little bit limited in the therapists that we have that can do the BFR, and so I kind of have to pick and choose the patients that I think would benefit the most from it and need it the most. So routine knee arthroscopies now, I don't send them over unless it's a special ops guy or somebody who's I really think needs to be on an aggressive accelerated protocol.
Right. And so if you got a big old multi-leg revision come in, you're a little nervous on it. You're comfortable with those folks starting it as well?
Yeah, absolutely.
Yeah.
The people who I think get the most benefit from it, who the patients come back and be like, wow, that's amazing, are the people who've been languishing in traditional therapy for 6 months or 9 months.
Yeah.
They come in, they still have knee pain, they still have profound quad weakness on exam, and you sit there and tell them, the answer for your problem isn't surgical. The answer for your problem really is therapy, and you get stronger. And they look at you and they almost get mad because like, I've been in therapy for 9 months, it's not helping. I need surgery now.
Yeah.
But when we first started talking about this, a patient comes to mind really clearly who had a knee scope by an outside provider, and I think she was a college long distance runner, and had a knee scope for something somewhat minor. I think it was a plica excision or something. He came to see me for a second opinion, and with ongoing knee pain and really, really profound quad weakness, and had been working with their trainers at school and hadn't been able to get back onto the team and return to long distance running at her previous level. And this is pretty early on in the course of the BFR. I said, well, listen, we got something that we can try, but you're going to have to work hard at it. But if you do, I think that you're going to get, significant strength gains from it. And we sent her, I think maybe you treated her, and did BFR on her. And she came back to see me 3 months later and literally gave me a hug in clinic and said she was back on the team and running. And so she had a rapid turnaround, and I didn't really even have to do anything. I just talked to her about it and sent her to see you guys.
Yeah.
So
yeah,
I think those patients who are so frustrated and haven't been able to kind of get over the hump are the ones who come back into the happiest, just because they've failed for so long.
Those are my favorites too, because after surgery you're already kind of down and out, and you just kind of expect to slowly progress and get better. But the ones who are so frustrated, and they're, like you said, 6 months out, and man, I just can't. I've done 90 frickin' quad exercises on this girl, and I don't know what's wrong. And then all of a sudden, it's like the muscle wakes up when you do it, and you can see it. I mean, it's like this rapid change. And so that's kind of what I tell a lot of people too. It's like, okay, if you're just starting this and you're getting some pushback or you're reluctant, I would go to an orthopedic surgeon and say, can I have your failures, or not your failures? You don't say that, but can I have your strugglers? Someone that comes 6 months later for a follow-up, they're like, man, I'm just still having a hard time, and I've done this traditional rehab, and send those to me. And when you turn those people around, that's the ones that you guys usually remember, like, damn, okay, now we need to rethink it.
I think that's absolutely true. Those are the frustrating patients in a surgeon's office that take a lot of your time, and that you sit there and you try to educate them, and you're really trying to talk them out of surgery whenever they are there trying to talk you into surgery. And so it's kind of this role reversal situation where you're like, you don't have any surgical pathology in your knee. You really have quad weakness, and I'm telling you, your knee pain is going to get better. And then you sit there and argue with them about how hard they've been doing in therapy, how often they're going. But those patients that come in that, return to your office, that legitimately are trying to get better, and they're working hard with therapy, and they just can't get over the hump. I tell you, those people do awesome, and are thankful, and they don't have to go through another procedure. And so it really is it's a win for everybody.
Yeah, that's something that's a little off topic here, but that was what was also amazing. Our time together for that past decade was, you guys were usually looking for reasons to not have to do surgery. There's no monetary gain on your end in the military from doing it. It's just more work when there's probably plenty of people that really need it. So you guys were always looking for a rehab solution, and we always had this big team approach where I could be like, it's just not working, Travis, and you would be like, well, the other side, hey, Johnny, I don't want to do surgery on this one. See what you can do. I think too, the one that's probably really annoying to walk into your office is the anterior knee pain patient that's looking for any solution that's quick. And you guys, there's just not a whole lot of solutions. And anecdotally, and now 2 published papers, we've seen that population seems to respond pretty well, especially from an analgesic effect from BFR. And so do you send those on if you get them to try and find someone that might be doing BFR?
Yeah, absolutely. That has solved a problem in my practice. And, prior to BFR, the patients come in with anterior knee pain, and I kind of give them a talk that anterior knee pain is similar to low back pain, that it's going to wax and wane. And I think that we can make it better with, altering a couple things, maybe trying to reduce how much they keep their knee bent, trying to get their quad stronger, try to improve flexibility of their hamstrings. And, you start trying to talk patients through that process, and their eyes kind of glaze over and think that, and they think that you're just kind of trying to dismiss them. So now, it's nice you kind of give them the full talk about anterior knee pain and say, but listen, I've got something that I think can help us jumpstart this process and get you going in the right direction. And we have this, new innovative therapy, and all of a sudden they get interested, they're back engaged in, in their outcome, back engaged in their treatment.
Yeah.
And they do well from it. And so,
that's kind of been the problem with anterior knee pain is we as our profession, we kind of like started moving away from the quad. And it's all, if you look at, kind of the leaders in this space, it's like, okay, get the hip strong, get the hip strong, get the hip strong. But part of that's kind of a cop out because everything you did that addressed the quad would make their knee worse, and you were in this vicious cycle. And so we're always like ignoring the quad, but it's like, man, if you get that quad stronger, it's amazing how much it clears that thing up. And most of these folks can handle a low load. And when they're doing BFR, all they feel is the damn tourniquet or the metabolites. They don't feel their knee anymore. You ask them, how's your knee feel? Like, my knee feels fine. It's my stupid thigh and this tourniquet that I feel more than anything else. So,
well, you're exactly right. And, and there's something to that with the amount of pain that they're in is, whenever their quad gets so weak that they have, basically worsening and worsening anterior knee pain, then it becomes more painful for them to do any exercises. So trying to get enough load on their quad to reverse that cycle becomes difficult because they're just not willing to tolerate that pain, and they feel like they're making themselves worse. And so being able to kind of redirect that pain towards muscle soreness and take the pain away from the knee and be able to lower the load that they need to get that muscle hypertrophy, it's really an effective process for them.
How about fractures? Have you ever sent any of your fractures?
Yeah, fortunately, I've got some good trauma partners that handle a lot of the fractures. But whenever I'm on call and get ankle fractures or plateaus, those patients have been sent from the trauma team over to get to BFR. And I certainly think it's similar with the restrictions that you'd have for multi-leg knee, where you want to reduce loads across the knee and want to reduce joint reaction forces while the fracture is healing, and the BFR can allow you to maintain those restrictions while still giving them means of regaining muscle strength after their injury and after surgery. So I think those patients can certainly benefit a lot.
Yeah, we think there's some things that might be beneficial to bone. Vascular endothelial growth factor comes out. It looks like when you do BFR, which builds capillary beds for callus formation. Interstitial fluid flow, the pressure between the muscle and the bone increases. And there's animal models that show tourniquets on osteotomies will heal those up quicker. There's receptors on bone for growth hormone to promote collagen synthesis. Myostatin goes down, which might increase bone-specific alkaline phosphate. So we kind of go into all that stuff, but then it's like, if none of that really helps the bone, at least they kept the freaking muscle strong during this limited use time. And really, the biggest BFR study in the world right now is a fracture study that we have going with Metric. We're trying to get 250 subjects on femur fractures. So that's the thing too. Some folks are like, I'm nervous with bone, but it's like, man, we got like 100 subjects already enrolled that have been doing it on femur fractures close to the cuff, and not an issue at all. So
Yeah.
cool.
Yeah, that could be pretty compelling evidence, especially for osteotomies around the knee. If you could prove the growth factors and changes in physiology would speed up the time to union, that'd be pretty valuable information, especially even for ankle fractures and high-end athletes.
Yeah.
Anything that you can do to increase the healing time and maintain muscle mass, get people back to doing what they want to do, would be really valuable.
Yeah. Well, in pretty much all the pro leagues, I can promise you most fractures, they have a tourniquet on now. What about, upper extremity? And that's kind of your specialty as well. So, like elbow and wrist makes sense, distal to the cuff. Have you tried it with your proximal stuff, shoulders?
Yeah, we haven't done a lot with shoulder stuff yet. I know that there's a study going on looking at, I can't remember if it was a rotator cuff repairs or impingement, and using, I think they were using tourniquets on their thighs to see if it created a systemic response. I think that could be valuable, but I haven't had much experience with it to date.
Yeah, we get that. I mean, that's kind of the number one question. What about the hip? Because there's so much hip pathology, and what about the shoulder? So, anecdotally, we see some positive results. If you put the tourniquet on one arm and you do bilateral shoulder type exercises, it definitely feels like the tourniquet side is working harder proximally. We have a lot of theories, and there are some published papers that show proximal changes. But if you're to say, what evidence do you have to show clinically changes in the shoulder? Nothing. There is a rotator cuff trial. It's not going yet. That's with Dan Buss up in Minnesota, and Tristan, who's out of Ashish Betty's lab in Michigan. We're close. I think we're almost there. So hopefully we'll get some shoulder data to say, yeah, this is doing something, or we're not seeing anything. I don't know if you remember. Go ahead.
Yeah, I was about to say, another thing that may be interesting to look at would be even response with something like adhesive capsulitis, because I think there's something really to the redirecting the pain that the patient's perceiving. And I think but I had my knee scoped a couple of weeks ago, and I guess not only do I prescribe it, but I'm also a client. But because I started using BFR 2 days after surgery, and I really think it has a significant effect on pain, because knee arthroscopy certainly isn't the most painful procedure, but it even having the tourniquet on, I felt like it reduced any symptoms I was having. And just like you said, you start feeling your quad muscle being tight and sore from doing the exercises. And so I'd be really interested in an adhesive capsulitis population, maybe doing some type of BFR in combination with shoulder manipulation, shoulder exercises, and see if there's any benefit to redirecting that pain and maybe people progressing quicker using the tourniquets than without.
Yeah, that's an interesting thing, and we've had one group out of Houston who's doing a bunch of research with us who said that they've even seen in their kind of arthrofibrotic knees that are lacking extension, that when after they've done BFR for several sessions, it seems like the motion's coming back where they kind of are plateaued, which is interesting. If there's an analgesic blocking a pain and they're able to push harder, or is there something else going on? There's a pathway that's being manipulated, but the analgesic effect is huge, and huge because we weren't really expecting that. I think Josh, you and I were first talking, and it's like, man, well, we could really flare up some pain symptoms with these tourniquets on, and they're in their tailor spatial frames and stuff. And then people get done, they're like, man, I feel better after this. And some people it's real transient, 10 minutes later, like, it's back. And some people it's like the next day they're saying, I still feel better. And two of the NBA teams, going into the playoffs, they were using BFR prior to the games with these kind of nagging injuries, just to get some analgesia, so the players, weren't feeling these kind of, tendinopathy and nagging kind of things during the game. What we don't know is how much dose, do we have to do, because we don't want to, for that scenario, we don't want to take the strength out of the limb. So can we do a small session of it, and how long is that effect? So it's an interesting question. And we all hate dealing with those frozen shoulders. So anything to help with those.
Yeah, and exactly right. Anything that you can solve those difficult clinical problems with, or give you one more tool in your armamentarium for addressing those tough problems is a benefit. And some of those patients, just like those kind of chronic quad atrophy patients, are so miserable, and they've been kind of caught in the same cycle that anything that they're trying new, they'd be welcome to try. So certainly something that'd be worth looking at.
For sure.
Just like you're talking about the analgesic effect. I'm only a couple of weeks after surgery myself, but I can tell a difference in what my knee feels like the day after if I've done BFR, if I have not. So, just like you said, it's probably individual, and there's a whole bunch of factors that go in and affect it. But certainly from my experience, it has been something that's made a difference, 24, 48 hours later if I do it versus if I, skip it for a weekend.
Yeah. And I think another kind of group to look at, especially if you're a new practitioner of this and you kind of want to ease into it with your docs, is if you get the potential to do it for prehab. So then if they're worried about the incision or whatever, then say, well, what about, can I see them for a few weeks prehab and maybe get that quad stronger? I think it's ripe for going after. We actually have a big prehab study going with a joint group over in Dusseldorf, Germany. It's just getting ramped up. So what are your thoughts on that? Do you ever send people for prehab?
Yeah, we do. It's usually in conjunction with maybe an acute ACL that you want them their effusion to resolve and get their motion back prior to doing surgery. And so certainly those patients we send over for therapy ahead of time. Or if in our population, if somebody's getting deployed and they can't have anything done for a certain period of time, then we'll send them to get some therapy prior to surgery. So yeah, I think that's certainly something that therapists could use to say, hey, let's do this. And if a surgeon is concerned about it. The other thing I would tell, if as a surgeon speaking to a therapist, if a therapist is like, having a hard time getting a surgeon to buy off on it, just like you said earlier, I'd tell them that you'll take their chronic quad weakness where they're not worried about any surgical incision things. And I think that they're going to see, profound differences there, and then slowly back it up. And that's kind of what we did is, said, well, outside 6 weeks after arthroscopy, I'm not that worried about it. So we can start, doing BFR after 6 weeks. And once you see that there's no issues with that, then you can start kind of getting closer and closer to the surgical date.
Yeah.
But you can also look at our literature that's been published that shows that we've looked hard for DVTs and looked hard for postoperative complications that were associated with it and found none. And so, and the other thing is to tell the surgeons that that we talked about a little bit earlier, is that the tourniquet pressure is so much lower and it's only on for a short period of time. So my guess is if surgeons are really concerned about tourniquet complications from BFR, is that they probably don't know the numbers involved as far as the pressures and length of time it's being used. Right.
And we talked earlier in this episode about just even in a very surgeon-driven journal of arthroscopy, that Brian Day and Robert LaPrade both had in that same journal two clinical commentaries of, I like BFR and this is how I like to apply it. I think even just having those available to be like, look, these guys are kind of the leaders in this space, and so if you're comfortable,
absolutely. But both are very, very well respected surgeons and well known in the the research community and publish great papers and very thoughtful in what they publish, and certainly aren't out there to push anything. And so when you read their commentary that there's saying there's early evidence to support and that they're using their patients, I think that's a pretty strong endorsement.
Yeah, because you guys like to hear each other. I don't know if you remember, man. So Matt Matava was he was the NFL Team Physician Society president, and he wanted to potentially bring me out to discuss this at the combine when we were first doing it. And one of the first things he said was, well, it sounds great, Johnny, but I would love to actually talk to some of your surgeons to get their perspective first before I bring you. So me and you and Don Gajewski went into Don's office and had a talk with Matava, and after he talked to you guys for a little bit, he's like, great, this is awesome. Let's make this happen. And same thing. I think last year, one of the big NBA teams, their doc was a little nervous, and I think I gave him your number. You talked to him, I think, right?
Yeah, I've gotten phone calls from a few surgeons at this point. I do remember that first phone call when you were talking about going to the combine, and told him I'd be happy to have that conversation. And but yeah, I've had a few conversations or phone calls from surgeons being like, hey, what's the deal with this? They're trying to put tourniquets on my patients. Am I going to cause a problem here? And so, there's enough literature out there now that shows that it's safe.
Yeah.
And I think there's literature that shows that it's effective over traditional modalities that we use. And so so I think all those questions have been answered from my standpoint, and now it's just kind of giving people anecdotal stories of what's your experience been, do patients like it, that kind of thing.
Yeah. Well, it'd be helpful. I'll do this. I'll put your cell number in our show notes so everyone can just call you if you're okay with that.
Yeah. Yeah, that sounds perfect.
210.
That's
okay.
right.
All right. So let's roll off of this BFR stuff and just talk quick orthopedic stuff here. So, all right, you're an orthopedic surgeon. What's some stuff that drives you crazy that you see from this side of the house, from the rehab folks, or nothing at all? There's got to be some stuff.
Yeah. I'd say we have a really good relationship with our therapist. At least I did whenever I was practicing in the military. And we were blessed to have really, really good, thoughtful people. There certainly are a couple of things that stand out in my mind that, whenever I found out about it, my head wanted to explode. But, one of the things is when you feel like you have a complex patient and you try to put in kind of restrictions that you think should be obvious, and those things are violated. A couple of years ago, we had a multi-leg knee, and the guy came back to clinic at 6 weeks and kind of checking his motion. And I started talking to him about how his therapy was going. He said he thought it was going okay, but his knee was kind of swollen and it hurt when he was doing therapy. So I asked him what exercises they were doing, and he said that he was doing a lot of leg extensions, and he was doing some side lane with ankle weights on. And so I kind of stopped. So what do you mean? And so he kind of showed me that he was laying on his side there, putting ankle weights on his ankle, and he was doing side leg raises. He had had a posterolateral corner reconstruction 6 weeks prior.
Oh boy.
So so my heart started beating a little bit faster, and so I called the therapist and said, what's going on here? You realize we reconstructed this ligament on the outside of his knee, and so putting various forces on his knee, you're stressing the repair prior to it healing, and may cause a problem here. And their response was, well, the therapy protocol says that he can do hip abduction. And so I certainly with thoughtful therapists who are experienced, I don't have to look so closely at the protocols to make sure that there's no type of exercise that would, cause a problem with the surgical site. But there have been a couple of those incidences where exercises for other parts of the body, the kinetic chain, probably would be prohibited in the early postoperative course. That they're doing stuff where they're stressing the surgical repair earlier than I want them to be. So those really are the main issues
I think
I've had.
And I think one of the things that therapists don't do enough of is understand exactly what the surgical repair is. Because me and you and Jay Gang and Lane Bailey and Andrew, so it's me and you from down here. Those guys are up at UPMC. They work closely with Freddie Fu. Lane is Walt Lowe's right-hand man down in Houston. We know exactly what the surgical procedure is. And if we don't know, we're either going to learn up on it or go in and watch you do it. And so it's kind of like common sense. Like, man, I saw that quarter. That was a tough repair.
Yeah.
Or even if it wasn't, it's like I don't want to stress that right now. And so a lot of it, people just stare at the protocol and half the time.
Right.
Unfortunately, these protocols suck usually. Unless it's really been vetted.
Yeah, I mean, so that's the thing is as I try to, empathize with a position where they're trying to get, patients in and out of clinic and they're busy and they're handed some protocol, and so they just start kind of going through what the protocol says, and maybe they're either not familiar with the procedure or they forgot what procedure was done, and so part of it is certainly communicating and making sure everyone knows the appropriate restrictions. But when you have a therapist that's experienced and knows what's going on, then you're a lot more comfortable knowing that there's not going to be anything that's going to jeopardize the surgical reconstruction. And if there's something that's unusual and that they're not familiar with, they're going to call you. And so to me, that's the real value, is if you have a therapist that you can team up with, that they're going to get the right care. And if there's anything that's unusual that you're not on the same page, that you're going to get a phone call and say, hey, what are we doing here?
So say I got a junior therapist, one of my interns, I'm out just goofing off, I'm not around, and they're a little nervous about something. Are you comfortable with them paging you, finding your number, texting you, asking you that question?
Yeah, absolutely. I get therapy emails, maybe not weekly, but every couple of weeks, and it says, we're seeing so-and-so, I couldn't find their op note. And I tell you, those emails or messages are extremely reassuring to me, and I'm thankful for them. So I never ever would be upset, irritated, or anything other than thankful if somebody calls and says, hey, I'm just trying to make sure we take the best care of this person possible, any special restrictions, anything like that. So
I think a lot of PTs just don't do that, and we all had a great relationship, and I had everyone over there in your apartment cell number, and sometimes I would just send something like, hey man, this dude's rocking it, and check this out, because you guys are proud of that repair, and it's cool to see it happen, but also be like, Travis, I'm worried, man. And I think part of it too is, I know he's going to come see you at 6 weeks. We're struggling. I don't want him to show up in your office and it's like, what the heck is wrong? Where's your motion? As soon as I see we're struggling, I'm like, we got an issue, dude. Yeah, we might not make it when he sees you, and we're gonna have to really think about how we're gonna go after this.
Yeah, just like you said, that information is always valuable. We certainly, as surgeons, we love to get our ego stroked. So if you send us a message and say, hey, somebody's killing it, that we loved hearing that. But on the other hand, if somebody's not doing as good as we expect, we want to get those messages too, because it's better to have that on your radar, so you can kind of plan. What you OR, how worried you are about them. I mean, if it's something like that, you're like, hey, they're going to do fine. There's nothing inside their joint that I'm worried about. Then you can send a message back, say, hey, just push them a little bit harder, encourage them.
Yeah.
Or something that you're worried about fixation. If somebody's had some adhesive capsulitis or in the shoulder. Anyway, if there's something that you're worried about and you get that message, then you can at least put it on your radar and say, hey, we may need to do something more for this guy. And it doesn't just show up in your clinic when you're 2 hours behind and now you have this big problem in your lap that you got to try to triage. So
say I'm post-op day 4. I've got a big old, a fused knee, hematoma going on, everything's shut down. We're working on it. Post-op day 7, they're not going to see you till 10. Still having an issue. This thing's real swollen. Would you want a call like, hey, can we see about doing something on this knee infusion, or ride it out till they see me in the next 4 to 5 days type of thing?
Yeah, I think it's hard to say a blanket answer to that. I tend not to aspirate effusions. I tend to try to get them to resolve on their own. But if it's 2 or 3 weeks going and it's really shutting down their quads and they're having a hard time getting their quads to activate with it, then I consider it somewhere in that range. I'll tell you that just from going through the experience myself over a few weeks ago, that was the only thing that bothered me after surgery was the effusion. The surgical sites never hurt really. I don't even know that I noticed them, but just having a big effusion for a few days and not bend your knee and having a hard time getting your quad to activate. I think that was a big thing that the tourniquets helped is once you could get your quads to activate and you just do a straight leg raise. Once you got over that and you could put tourniquets on and do straight leg raises with that, start getting a little bit of your quad firing. I feel like that really helped the effusion. Start getting better. So
Yeah, that's the thing. It's kind of just like chasing your tail. The effusion keeps the quad from firing. Quad doesn't fire. It doesn't seem like it gets the effusion to kind of pump out. But I think that's the beautiful thing again with BFR in those cases, because you're probably getting down to the big motor units, even with something like quad sets or straight leg raises. And next thing you know, you're getting a good kind of push of that effusion. So it helps with that chasing your tail. So, okay, last kind of like what I call a Travis scenario. I've got an incision that's not looking 100% great. No fever, no signs, hard signs of any infection. Just kind of like, ew, man, this incision isn't closing like I think. They're not going to see you for another 4 weeks. Call you up then, or just kind of keep monitoring.
Yeah. No, send me a message. I'd want to know about it. If again, I'll have the benefit of knowing, do we put allograft in there? Is there something else I'm concerned about infection wise? And so, if somebody wants to take a picture and text it to me, if somebody just wants to give me a call, typically if somebody gives me a call and says, hey, I'm worried about a wound, I say just send them over to clinic and we look at it. So if I certainly, with our relationship and your extensive experience taking care of these post-op patients, if there's somebody that you're concerned about, then I want to be concerned about it also and see if there's something that we need to do.
Cool. So is your practice going to change when you go civilian side? You're going to be doing a lot more BTPs now?
Yeah, it's funny. It'll be an interesting transition. We always think the grass is greener on the other side, but
oh man,
my guess, I know my guess is I'm going to look back on my military patients, my military practice, and miss it. I mean, it's just as you remember the best patients in the world, and and you get sent real problems and people that want to get better, and so it was great practice. There's certainly frustrations in the administrative and bureaucracy side of things, but as far as the patients and the practice goes, my guess is that it may have been the best ever.
I know you talk to all of our friends that are out, and I hear that so much. I was just with Joe Shue, and no one hated the end of his career as much as Joe Shue. I wanted to get out, but we were together at the Special Forces conference, and he was like, "Man, I miss it." And looking back, that was like the most amazing time of my career. So definitely, it was definitely worth it. So
yeah.
Well, cool, man. We'll wrap it up there. Thanks, Dr. Burns. The civilian world's getting an amazing surgeon down here, and so if anyone in the San Antonio area definitely is looking for a fantastic surgeon, especially a sports medicine doc, or anywhere in the country, we know people fly all over. So you're going to be at Ortho San Antonio with Matt Murray and Matt Moret, right?
Yeah, it's going to be me, Matt Murray, Matt Morey, and Jesse DeLee, and John Henchy. And so I think we'll have a good group of guys. That's
a badass group, man.
Yeah, it should be fun, and it'll be fun to turn a new page and get into a new chapter of things.
All right, Travis, let's go grab a beer here soon, man.
All right, brother. Appreciate you. You have a good one.
Okay, later.
All right. Bye-bye.
Now let's take some questions. We got a bunch of good questions from our last podcast. And you know what, guys, I need to clarify something because we try to be evidence-based, science-based podcast. Our first podcast, which wasn't a true podcast, it was a practice podcast to just see if we could get this thing up on iTunes. We had a deep discussion about Tori and her school not having a mascot, and that really rubbed me wrong, and so we went deep into we got to find a way to get you guys a mascot. So if you listen to the last podcast, it was a bunch of yapping from us of looking for a mascot. But then, guys, guess what happens? Tori goes home to her husband, and she's like, "Oh my God, guess what Johnny made me do today? The stupid podcast, and all he talked about was us not having a mascot." And her husband's like, "Tori, you guys have had a mascot the whole time." All I did was Google her college, and on the front page, the stupid mascot. It's Wildcat Willie, for everyone that's wondering.
But I'm still going to talk to him about being vape.
You like vape better? Yeah, Wildcat Willie. I mean, it's kind of cute, but it just makes no sense. And the other thing we have to clear up, we were all excited because that first practice podcast, we got 3 subscribers and we didn't even really leave it on for more than a day. And we are like, we're going to rock this world. Well, and then I found out that I think all 3 subscribers are on this call right now. So we weren't really as cool as we thought. All right. So here's questions. So Tim put in, is it beneficial to do BFR for multiple sclerosis patients? Is it contraindicated? Is there any research? Are there special considerations, i.e. overheating or fatigue? So Zach, I know that you've had conversations with one of our research partners on this. Why don't you chime in first?
Yeah. So we have some data. There was a preconditioning study that was done, and they showed following the preconditioning, the walking, they showed about a 10-meter increase in walking.
Zach, hold on. So because we've been saying BFR, we're going to mix this term in preconditioning. What does preconditioning mean?
So preconditioning, or I refer to it as ischemic conditioning, and basically what it is we run the pressure up the limb occlusion pressure, and from there we introduce full ischemia for 5 minutes, and then we reperfuse for 5 minutes, and we cycle that 3 times. And you can either do that pre-exercise or pre-training bout, or you can do it post. So if we do it pre, we just call it ischemic preconditioning. If we do it post, it's ischemic post-conditioning.
Right. And so what we don't know is how many bouts are needed, how long of time really, how long of rest. So, but we're stealing this from remote ischemic preconditioning, which there's a ton of papers on that to spare heart muscle, to spare the kidneys, to spare the liver. And those guys have done a lot of work already over decades. And so I think our general understanding is it seems like a work to rest ratio. It needs to be 1-to-1, or not work, but inflation deflation is 1-to-1. And then it looks like it needs to be at full occlusion. So BFR, we typically, or we don't go to full occlusion, but ischemic preconditioning, it's like, I think it needs to be at full occlusion. So we use 100% of limb occlusion pressure, right?
Yeah, exactly. And I think the reason why we say it needs to be at full occlusion is because when you look at the studies that have been done, it's with a clamp. And so they completely clamp the artery. So it's going to be full ischemia.
Okay.
And so from there, so we have that aspect of not doing exercise with the cuff on, but simply doing this conditioning prior to the training bout. And then what we see is an increase in walking distance in the group that had the ischemic conditioning.
But that was MS
there's
subjects?
a clinical, that was with MS subjects. Yep.
Okay.
And so then we have a clinical trial that's going on currently. It just started in June, and it's enrolling folks right now with severe MS. And they're going to do 2 groups. One's going to be a BFR group, and it's a walking-based study. And then the other group is going to be a control group that does not have any cuff on. It's an interval-based walking study for 6 weeks, training twice a week. What they'll do is they're going to do a 1-to-1 ratio of walk to rest, and it'll be for a total of, say, 6 minutes. So during each bout, it's going to be 1 minute of walking with the cuff on, with 1 minute rest, and then that'll be continued out for 6 minutes. They're going to do that for 5 total bouts. So we're going to get roughly right around 15 minutes of ischemia. The kind of caveat to this, it differs from a lot of the aerobic stuff that we've seen so far, is they're going to deflate the cuff in between each set. So that's going to, I think, pose a little bit of a limitation. But either way, the point of their study is they just want to assess the safety and feasibility of BFR.
Yeah,
that's
the one going on in Italy, right?
That is correct. Yep.
Italy. Yeah, so that was interesting that they say severe MS, and so they have these, kind of inclusion criteria that you have to have worsening MS symptoms, I think, for like over 3 months or something like that to even enroll. Which correct. That alone is going to make, if I'm looking at that study, it's like I bet enrollment's going to be hard.
It's going to be tough. Yeah.
They have. I think I saw they they have it. You know, they got a 3-year window for completion. We'll see how many they get. Do you remember what the N was on it?
I don't see it. So let me look.
Well, anyways, I know
Yeah,
that. I don't know those guys. We don't have any relationship with them. I think there is a fatal flaw in that one is the way they're determining pressures on it. So they're using systolic blood pressure, and then they are
correct.
using
It's
that.
40. It's
So
yeah, and it's low. It's 40% occlusion.
But they're
40% systolic blood pressure.
They're probably getting blood pressure in the upper extremity, right? I mean, I didn't see they clarified that. That's what most people do.
They did not.
Yeah. So that's the problem, right?
And it's they're looking for 40 participants in this study.
40, yeah. But okay, so a lot of people, here's a problem with these studies. They will like take a blood pressure in the upper extremity, take that and say, okay, systolic is 130. And then they go down to the lower extremity and they'll use that pressure at 40%. That blood pressure in the lower, for one, that's a problem all the way around. Blood pressure is just one of many variables. So, I mean, if you're going to do a study like this and really help us like understand how to standardize this and what the effect is, you can't just go off of blood pressure. So they're probably going to get a very low occlusive stimulus, which you know.
And then they're gonna deflate the cuff. In between sets.
So we just got to be careful because here's a couple things. I could say, look, yeah, we did it in severe MS and there was no problem. Well, you use this kind of poor design where we're using blood pressure probably in the upper extremity, and then you took it down to the lower extremity, which is already screwed up 100% of what we know for limb occlusion pressure. And then you even took that down further. So the occlusive effect is probably minimal. So people in the clinical setting that are using Dopplers, we can't even use that anymore. We don't know, what to use. So safety, we still don't know from the way that it's clinically really being applied in most of the stuff. And then the other thing, if they don't get a good result, well, it's like you might have had such low occlusive pressure. How would you expect to have got a result when you're using something like blood pressure in the upper extremity going to the lower extremity? The variables for limb occlusion pressure are, the size of the limb looks like it's one of the number one determinants that we have to use. The density of the limb, the width of the cuff, the placement of the cuff. Is the cuff tapered? What's their blood pressure? So all of those have to be accounted for, and it won't be accounted for in this study. But good on them. I mean, they're at least getting the ball rolling in a population. You get a lot of questions.
And then I was going to say the other study that is currently they're going to ramp up here is up in Baltimore. And what they're looking at is basically is the opposite. So they're looking at high functioning MS folks. And from there, it's going to be a strength-based program where they're going to do 3 exercises with BFR. They'll use the Delphi device. It's going to be seated knee extensions, a squat, and then a straight leg raise. And so they're looking again from a safety standpoint, a feasibility standpoint, and then an efficacy standpoint. Looking at outcome measures, they are going to look at fatigue, I think acutely, and then at 24 hours. And then they're going to look basically at strength in the lower extremity, and then 6-minute walk test as well. And then they have not decided, but they're going to use an MS specific outcome measure as well.
Okay. And so we know the group you're talking about. Is this MS kids that they're doing it on?
That has not been, I do not know.
Okay. And have they started pilot? Is it already going?
That is a pilot study they have funding for.
Okay, awesome. Well, and that's a good group. So I think we'll get some good information from that. So really, Tim's question, are there any research? There's one published trial, and we have 2 trials that we know of ongoing. One with a group we work with, one we don't. Right?
Yeah, correct. And I think one of the big mechanisms potentially is like when you want to implement that, one is like he suggests is, monitoring fatigue. And I would monitor fatigue acutely after and then at 24 hours. And then so you can use something as simple as like the fatigue severity scale, something along those lines. mechanisms that may potentially help is, IGF, which then will have an impact centrally and peripherally in oligodendrocytes and swan cells. Potentially, we'll see a change with VEGF as well, which will have central nervous system and peripheral nervous system myelin effect as well, and then potentially a growth hormone role as well with myelin. So that would be the potential mechanism that we would look. And then Tim, with that being said, the data that we have when we look specifically at either VEGF or growth hormone, those studies were done with one exercise, and it was knee extension. The other thing was the IGF study that we pulled from. That was a squat and leg curl study. So with that being said, you don't have to do a ton of exercise to spike these factors. One exercise to two exercises seems to get us a pretty good response. So it may be worthwhile just to do one or two exercises within this patient population, at least early on, to see how they respond.
I would say that's key, because we did have one individual. She was actually in San Antonio. I wasn't working with her, with a group here, but she kind of had a little bit of exacerbation of her fatigue symptoms for days after her first session. And they just did too many. I think they did like 3 or 4 exercises. Like, man, you guys, come on. One at least the first day. Yeah. She loved it though. She came back. She took like 10 days off, and she has done well. I think, maybe we can get deeper into this MS wormhole with things like VEGF and its neuroprotective factor. These people already have compromised myelin sheaths, so that's where we got to be real careful when we're looking at pressure gradients being created with your systems. One thing we really, with these Delphis, is we keep these pressure gradients at a low level, which we're not maybe compromising demyelinating nerve. The one other thing I think with MS we got to think about though is they do kind of have some compromised vascular systems in these vascular beds. They get these MS plaques. So I wouldn't, if I had an MS patient, I wouldn't just go right at it. I would talk with the doc and make sure that they're comfortable with it. MS isn't a contraindication on our devices, which means that, basically they could have the tourniquet placed for surgery, and it's not contraindicated. So it's not a direct contraindication, but because of these unknowns, I would definitely get the medical team on board. Cool. All right, Tim, hope that helped. And everyone who answered their question, I think we picked 5. You get a free T-shirt. So Tori's going to reach out to you and get your shirt size. These are the nice shirts too. Kyle, I think he just cut out right when his buddy's question came on. So this is from Corey. At what point would you transition a patient off BFR to normal loading, or is it better to continue with BFR as they get into more normal lifting? Kyle, did you hear that? Are you back on?
Yeah, I think I'm back on. I don't know what's going on with my internet.
This is from Corey. When would you take them off BFR and get to normal loading, or would you do BFR with a more normal lifting?
Yeah, so it varies probably every patient I treat. I would say I'm always kind of looking at when can I get away from BFR and move towards heavy lifting, because you have to get there.
Yes.
Just to build load tolerance and tendon resilience and all those things that are important for our people to get back to doing what they want to do. I think that, there doesn't have to be a hard endpoint though. I think too often we're kind of looking for, all right, now we can run, or now we can do plyos, or now we can lift heavy. And for me, quite often it's some sort of a hybrid. It's like, all right, let's try to do this squat type movement heavier and get more towards those ACSM guidelines, but maybe we're still kind of doing our long arc quad type movement with BFR. And then as I transition farther, I'm still kind of looking at their muscle quantity. If they have a deficit in muscle size, I'm gonna keep doing BFR because I just want to make sure I've given them enough stimulus to restore that muscle size, because we need to get that back for them in order for them to develop force at some point. And then moving kind of farther down, like for example, I as I said, I've done a variety of things, but one of the things I've kind of been tinkering with recently is kind of having like a heavy day where we really load that person heavy the first day, and then if they're 3 days a week, then the second day is just a BFR day.
Right. And that also that tests your joint, and if they flared up
right.
and heavy, it's like, okay, maybe we're not ready for this yet.
That's exactly right. And so you're building a load tolerance that whole time. So I think there's just kind of this blending of when you're doing what you're doing, and you're kind of feeling it out as you go, and it varies just about every time that you do it, probably, which is not what we often want to hear. It's nice to just have an answer like this is what you do, but yeah, unfortunately, it's just not how it works in the clinic.
Well, and I think you made a good point. Like, okay, maybe I'm doing some multi-joint moving away from BFR, but I've still got a deficit in maybe strength,
right.
muscle quantity or quality. And George
right.
Davies and I spoke at Symposium Americas several years ago, and he drove this point home. He's like, man, we're so damn functional that we quickly move into doing all these fun, crazy exercises when this ACL is still significantly weak and still significantly, atrophied at the quad. And it's like, get that back first.
Right.
You're sitting there trying to clean up a damn squat. And it's like, man, I bet if this guy didn't have a 30%, deficit in strength at his quad, that squat would clean up pretty quick.
Exactly.
So it's an easy way to do a low load and keep hammering that away while you're maybe moving into some functional things. And I know all of us agree. If you can lift heavy, right?
Yes.
Everyone's like, you guys just do BFR? No, man. I hate those damn tourniquets. If your patient can lift heavy, get them off the tourniquet and get them lifting heavy. That's the goal, because you want them to leave and say, okay, keep going to the gym and start putting some loads on there if you can tolerate it. But if you can't, then BFR is a nice alternative. That's kind of our saying that we had at the Center for the Intrepid. It's, why are you doing that exercise? Well, I'm doing that exercise for strength and hypertrophy. Okay, do they meet the loading guidelines that we know from ACSM? No, they can't, because they have pain, they have surgery, whatever. Okay, then if you have to use a lower load, then put the tourniquet on. That's about as black as white as I can get with it, and then slowly transition off. What we don't know, and this is a question we get, what about lifting heavy with the tourniquet? Do you get something extra from that, right? So we don't know. You might, maybe off an animal model, you might have less muscle damage, so you can maybe lift more. You have more protein synthesis and less protein breakdown. University of Michigan's ACL study is looking at higher loads with tourniquets. So we'll see. Hopefully it'll be done here soon. So, all right. So I don't think we had a great answer for you, Corey, but it's a gray area, that's for sure.
Hey, look, Johnny, the only thing about Corey, man, like, I know he really wants that T-shirt, I'm sure, but you need to understand how I met Corey. Did I ever tell you that story?
No.
So he was a student at Hardin-Simmons University, where I'm an alumni from. I went there to talk about, I wasn't talking BFR at the time, but I rolled up in the parking lot, and there's this truck, and it said, the bumper sticker says, "Keep College Station normal." And I went, oh, here we go. And so I made a reference to that bumper sticker in my talk, and sure enough, it was Corey's. At which point I went into something about, look at, what would Texas A&M be without the University of Texas? They would just cease to exist. I mean, we're in their fight song. It's
exactly.
They really wouldn't have a purpose. So,
yeah.
So before you send that shirt, maybe put like a sticky note for front and back for Corey, so he just knows how to put it on.
Yeah. Well, we'll send him a Keep Austin Weird T-shirt.
There you go.
Well, and I thought Kyle was going to go into an explanation of how he met Corey in a bar, because that's where I assume Kyle meets everyone.
Yeah, exactly.
All right, guys, I got to go.
All right, Kyle, that was a good love story to end it on with you and Corey.
Yeah. All right. We'll talk to y'all later.
All right. So this is from Jordan. Is there any research or data out there pertaining to using BFR for joint effusion? If so, what is the mechanism? So you guys thought. So I assume he's saying, let's look at this from two ways. Does it decrease joint effusion, or does it increase joint effusion? Because we've had people say, well, yeah, this guy, had a sprained ankle. We did BFR, and it seemed like his effusion went down. But the big question you get is, does this make joint effusion worse, especially in your postoperative patients? So you guys go with that first.
Yeah, I mean, just from my limited experience and everything that I'm hearing, I've heard a few times of some people that got a little bit of additional joint effusion, but that seems to be very. I've heard anecdotally from some people that they have less joint effusion. Maybe there's a little bit more of a muscle pump kicking in, a little bit more venous return. I don't know that it would, have any effect on the lymphatic system, but maybe. So, I've heard a little bit of both, more so on, less joint effusion than adding joint effusion, and I have not seen any research out there on it. So,
yeah. What about you, Zach?
Yeah, same with Ben. I don't know of any research specifically looking at it. How I look at it and consider it in a post-op population would be, swelling in and of itself is going to be normal. And we know, like the ACL, they swell for a long time. So just the simple fact that it swells isn't necessarily a big deal. But if we notice that the cuff is causing it to swell, or this joint effusion is significantly worse and it's for a long-term period, at that point in time, I'll stop using the cuff and then kind of wait until swelling and the effusion's under control. Yeah. At that point in time, then reintroduce it. But yeah.
So what we know from the tourniquet literature is not a lot. The engineers up there at Delphi and their scientists said, well, from what we know, tourniquets don't increase intra-articular swelling, but there's really nothing published on that. And you're not going to know because they're using tourniquets in the surgical suites with an open joint. So obviously we're not able to tell, is it making the swelling worse or anything while it's on. But anecdotally too, I agree with you guys. We haven't seen that it makes the effusion worse. In our knee scope trial, we just tape measured the joint lines of the BFR group and the control group, and there was no difference over time in what we saw there. But I do agree with you, Zach. If the swelling gets worse, or if the swelling's bad, calm that down first. It's amazing how much better your rehab goes once you get the swelling to calm down and the pain under the swollen joint's a very painful joint too. The one thing that we have is a contraindication or a risk is these extra articular incisions. So like a Tommy John, a UCL reconstruction, an MCL where they've taken down the medial joint line. Outside the joint, it seems like you can get some swelling. So with those, I would definitely monitor the wound to make sure you don't get dehiscence. But if I have a routine knee ACL, that's kind of redundant, knee and ACL, or a routine ACL, and it's just scoped out, I'm not worried about BFR increasing swelling from what we've seen with all these cases. Mechanism-wise, like Ben said, I don't think we have a mechanism. Dr. Cox, when I was down there teaching at Andrews, he was really interested in this fifth space, this lymphatic space. Is there a clearing of it? Which is an interesting theory, but we don't know. Go ahead, Zach.
Yeah.
Cool. All right. I thought you were going to say something. All right. This is from Amanda.
No.
Can BFR be used during rotator cuff rehab if the Delphi tourniquet is placed proximal on the limb to restrict blood flow? How would this aid in rotator cuff rehab and those muscles still receiving O2? Well, for one, boy, talk about the number one question we get at every course, right? I mean, you almost barely start teaching and people say, okay, what about proximal to the cuff? So we're, in this podcast, we're not going to go into proximal yet, but we definitely will, because that's a big question. So I'll take this first. Can it be used during rotator cuff rehab? Well, certainly yes. What evidence do we have to show that it helps? We have a big goose egg of nothing. Anecdotally, it definitely seems like it has some benefit. If you do, like bilateral scaption exercises, one with the cuff on one arm, the other arm not, it definitely feels like the arm with the cuff, especially at the shoulder, is working a lot harder. And there's different kind of ideas on this. It's either downstream fatigue, where if I put a cuff on my thigh muscle and I do squats, the quad gets so tired that my hip becomes a prime mover. We have some studies that back that up. These bench press studies where there's higher EMG at the pec and changes at the pec when they have the cuff on, because the speculation is you fatigue the tricep so much that these trunk muscles have to become more of a prime mover. So that's one theory. The other theory is this systemic response that gets some people really worked up when you talk about it. But it's, can you put the cuff somewhere else and get a response at a distal muscle or a muscle that's not directly related to the cuff? So we'll get into that deeper. We are planning a big rotator cuff repair study with Dan Buss up there at Alina Healthcare, along with Tristan, who's at Ashish Betty's lab in Michigan, to hopefully answer this question a little bit better. But we use it in all of our proximal shoulder rehab. It seems to be beneficial. Anything you guys want to add to that?
I think you got it from my side.
Yeah, I mean, I think the big thing with the systemic changes is the muscle group that you're working, or the muscle group you target, has to be active.
Yeah.
So just because we put the cuff on doesn't automatically make that muscle group either hypertrophy or change its strength.
Right. So that's the problem. That first 6 weeks in rotator cuff rehab, when you really aren't doing much of anything, range. Yep. Really. So what can you do during that first 6 weeks? Well, what we're going to look at is, having it on the lower extremity to kind of look at this whole systemic suggestion, and then at least doing your isometrics in your upper extremity range, and hopefully getting a T3MR to just see, is there changes at the actual tendon itself? Did we reduce fatty infiltrate? And then from 6 to 12 is when we can start throwing it on the arm and see if there are additional changes there. So that's the way we skin the cat clinically with our rehab with these protocols, but hopefully the study gives us some better insight. Okay, last question here. Ethan, is there any potential in using functional dry needling and PBFR in combination to speed up recovery from an acute muscle strain? Physiology and mechanisms of both modalities seem to tie in well together. I'm going to have to pass on this one because I don't really understand the physiology. I haven't looked at it of dry needling. Zach, I think you're the only one here that might understand that one a little bit better.
Yeah, so just to keep it simple, using the needling following a strain of any sort, where I find that we get the greatest effect from that is we can reduce that muscle spasm from the actual strain of the muscle. And in my experience, it's the spasm of maybe the muscles trying to approximate the two ends of the tear, bring them together to help healing. But once we basically reduce that spasm, we can have a significant impact on mobility of the tissue, and then the ability to basically either exercise or simply just walk with minimal to no pain. So from that standpoint, that's how I use that. And I use it relatively early in a treatment session. So regardless if we're talking a muscle strain or just if I need to impact someone's movement patterns or something like that, we'll go ahead, do that treatment initially, and then we put the cuff on and do targeted exercises to the tissue that I want to treat. So if it's a hamstring strain, maybe we just start with something that they can tolerate. Could be something like a bridge. It's something that we get a little bit of hamstring activation out of, but it's not a full-on targeted treatment, say like a leg curl. And then from there, I just progress the treatment to what they can tolerate with a more direct exercise to that muscle.
Okay, makes sense. Yeah, and so I will say, soft tissue wise, these soft tissue injuries, we've seen some positive changes, and it seems like it might be something to go after. Paul Silvestri and I put a little case series paper out. It wasn't a real published. It was in training conditioning at Florida for some of these hamstring injuries they were getting and using BFR. And on the imaging, it looked like they were getting a better regenerative response, less fibrosis compared to the historical data. The guys out there with the Rams have also seen some positive changes with BFR for these hamstring injuries. And so I think the number one thing that we want to look at from a soft tissue standpoint is how can we reduce fibrosis and how can we get muscle regeneration.
Yep.
And so you have to upregulate the progenitor cells, the growth factors. That's probably the satellite cells that are going to be a new myocyte, but also maybe getting these hematopoietic progenitor stem cells to come out of the bone. But the fibrosis is the key. We gotta take that down. And so we'll get in deeper of the pathway that we want to tackle with this BFR. But I can see, man, whatever you can do to get the muscle to calm down from a spasm. I mean, I'm not going to get into the dry needling debate, but if it takes the spasm down and you can tolerate it, then man, go for it. I would say.
Yeah, that's the thing, I think. And then like you said, I mean, with the cuff, the true benefit with the cuff is we can do a low load exercise that otherwise, to produce that progenitor cell response, we would have to use a much higher load. We can do it with a much lower load. It's a lot more tolerable to the healing tissue and just kind of really jumpstart the progression.
Exactly. All right, man. Well, guys, we went way too long again. I'm going to go wake Tori up. And I think we will close this off until next time. Appreciate you being on.
All right.
Enjoy the rest of your day, fellas.
Thank you.
All right.
Thanks, Johnny.
All right.
Bye.
All right. Yeah, bye.
Thanks for listening to the Owens Recovery Science Podcast. Owens Recovery Science is a single source for PTs, OTs, ATCs, DCs, MDs, and other medical professionals seeking certification in personalized blood flow restriction rehabilitation training. Find them online at owensrecoveryscience.com.